Okay, good.
Okay, awesome. Fantastic. I'm so excited. Fantastic. Okay.
Nice to
How was
see
the
you.
theater?
Well, it was fine. How are yours?
My day was good.
All right.
Yeah, awesome. Awesome, awesome, awesome.
Nice.
So we'll just wait for everyone else to join up. So it will not take too much of your time, but we need to pick your brain. We need to pick your
Okay.
brain. Yeah. So what case did you have today?
Well, I just did embryo transfer. So
Oh,
for
nice.
uh,
Nice.
one, yeah. So
Fingers crossed.
she had some flight delay. So just came in from Delta State, and I had to
Okay.
wait. I had to wait in the office for her. Yeah.
Okay.
But it
Okay.
went well. At the time you called, I was, in the middle of the procedure. So
Procedure. Okay. Okay.
that was why someone else had to pick the call. Mm.
Okay. Awesome.
IJ, looking very good. Mama IJ.
Thank you.
Mommy IJ.
I'm trying.
Nice.
Thank you.
Nice.
I'm trying.
Nice. Nice.
Okay. Yeah. So just wait for a few seconds because we had some people on before and I'm sure they run away now.
Okay.
Shouldn't take too much time. Shouldn't take too much time. Yeah. Yeah. So basically, right now, you're you are. Please explain what area of ONG you're into now.
Reproductive medicine.
Reproductive
Simple.
medicine.
Yeah,
Okay.
reproductive medicine. By reproductive medicine, of course, it cuts across almost all the areas, but you concentrate more on issues of reproductive health. Yes, fertility is very prominent, but and appears the most popular, at least as far as Nigeria is concerned. But of course, you get to deal with literally every other thing in ONG, um, you know, contraception, fertility, um, baby making, just name it, cancer, But I really concentrate now on, fertility. But I do very little of obstetrics, very little of all those surgeries and all that. So we have a unit, reproductive medicine unit. So all the gynae patients that come with fertility challenges get sent to the unit. So we sort them out. Okay, we range from the mild things like you're trying to stimulate and get to monitor timed intercourse, or you get to do IUI, or you go up to do IVF. And then, of course, when you get to IVF, all kinds of things you need to consider. So that's what takes my time now, and not too much of the somebody's bleeding, somebody's doing all of that.
Okay. So
So
what hospital is this?
it's a public institution. It's a federal medical center in Jabi, Abuja.
Okay.
If you know Jabi, Abuja well, that's so we have a reproductive medicine units there, and yours truly started it, and
Mm.
yeah, yeah, and somehow um, we're doing very, very well. In fact, beyond my expectations, really. So we have
Fantastic.
clients from all over. We have clients coming from the UK, the US. It's more expensive, getting to do IVF abroad and all that. So we receive lots of clients coming from outside. So, and quite a number of them have been successful too.
Nice. Okay, so let's just get to it. We are going to have the replay of this would be available for 24 hours. So anyone who missed out the beginning will still be able to follow. So I was just wondering, and our audience, they're just regular moms. They might not be any medical person, so we will need to dumb it down as much as possible.
As possible.
Yes. Okay, so I'd like you to describe for us what a miscarriage is, and what difference between a miscarriage and a stillbirth.
Yeah, when you talk of a miscarriage, I think you talking whether miscarriage or stillbirth, you dealing with a pregnancy loss. There's a loss of a pregnancy. But I think what defines a miscarriage or makes it different from a stillbirth is if the pregnancy loss happens early in pregnancy. Okay, and there are all kinds of cutoffs. What WHO gives is 20 weeks of pregnancy. So if you have a woman having a pregnancy loss before the pregnancy gets to 20 weeks, you will call that a miscarriage. But if the pregnancy has gone beyond 20 weeks, you will call that stillbirth. In the US, the cutoff is 24 weeks. So if you have a pregnancy loss before 24 weeks, they call that a miscarriage. But if you have it above 24 weeks, they call that a stillbirth. In our environment in Africa, because the essential thing there is actually the probability of having a live birth, from a woman delivering her baby at that time. So we call that age of fetal viability. So there's a very high likelihood that if a woman loses her pregnancy later, in the late stages of pregnancy, that's as good as a baby coming out, okay, and with some good care, that baby can go on, to live well and nothing happens. But if she gets to lose the pregnancy early, then of course she might just miss the baby. So in our environment, because of lack of all the facilities, gadgets to take care of very small babies, so our own cutoff age in this environment is 28 weeks. So we would define miscarriage in this environment as pregnancy loss, before a woman gets to 28 weeks, because 28 weeks. So if I may just recap, World Health Organization puts that at 20 weeks as a cutoff. In America, you have 24 weeks. And in Africa, in the environment, is 28 weeks. So any pregnancy loss before each of these gestational ages, you would call that a miscarriage. But if the pregnancy loss happens after that, you will call that a stillbirth. I think the important thing here is that either way, however you look at it, although there are a few things that differ, a pregnancy loss is a pregnancy loss, and of course it has a huge impact. Okay, not only on the mom, but on the family. As a whole. That you lose a pregnancy, of course, that's like losing a human being. So what people don't remember is that you can have someone born, maybe dies at 3 years, and it's like, oh, a child died. But truth be told, if a woman gets to lose a pregnancy, it's to some like having a child die. So, and lots of women go through that emotional distress, and of course, health caregivers and others, family members, should be conscious of that, and that the woman may have to grieve, I forgot to mention that there is, you may also want to mention a case where a woman may lose an unwanted pregnancy, because all the while, remember, we're talking about a wanted pregnancy. Okay, sometimes It may not be very convenient for a woman to keep a pregnancy, and she just wants to let go of the pregnancy. It's still a pregnancy loss, and and the issues that may come up as a result of this are pretty much the same, as if she gets to lose the pregnancy, spontaneously, she gets to lose a wanted pregnancy. So I think if you look at it, like, pregnancy can be wanted or unwanted. So if you lose any of those pregnancies before the age that is described as fetal viability age, which is dependent on the environment, okay, you'll call that a miscarriage. But if you lose the pregnancy after that age of fetal viability, you will call that a stillbirth.
Okay. So, please, in our environment, or in your experience, in your practice, what has been the most frequent cause of miscarriage? Because a lot of times people always want to, I think maybe it gives them some sort of closure to be able to pinpoint what exactly went wrong.
Okay. Before I get there, generally speaking, it must be mentioned here that that not all pregnancies will go on to become babies. That must be said. Okay, because fertility and pregnancy, baby making is a very complex event. And sometimes you may have some of these events not perfectly orchestrated the way it ought to be. So, you have the end result as a miscarriage. So between 10 to 20% of women are going to have, of pregnancies are going to end in a miscarriage. However, a few things have been identified, okay, as being the cause. Generally, as healthcare people, we would always look at problems from two main sources. You may have problems that are related to the mother, okay, or to the parents, carrying the baby, or you may have some problem related to the baby that was about to develop. Okay, it must be said here that 50% of miscarriages are actually due to problems with the baby. Basically, we do know that every life starts from a combination of two cells. The cell from the woman is called the egg, or the oocytes, and the cell from the man is the spermatozoon, or the sperm. Okay, these are two cells that will have to combine. But more importantly, there is the basic structural unit that codes for every bit of what comes out as a human being. Okay, how your eyes develop, how your hands, skin color, and every of the traits that a human being comes up with. It has been programmed in such a way that it is what the inner core of this cell would tell the rest of the developing human being to turn out to be, that it would turn out to be. So you call that inner part the nucleus. So the nucleus harbors, the basic functional units, which some of us know as the gene. Okay, that this gene is responsible for, determining what an individual, what a human being turns out as. So we find out that in 50% of miscarriages, there was a problem with how the genetic apparatus was formed. So you have, chromosomal problems as being the commonest reason why, miscarriages happen. It just means that the baby was not formed normally. And naturally, the body has a way of just getting rid of whatever is not formed properly. But it must be said that 50% is from genetic problems, chromosomal problems. However, There may be other factors, okay, that may also be responsible, to miscarriages happening. We may wish to group them into things like infections. Okay, there are certain infections that may happen, in a woman that may make her prone to miscarrying her baby. Infections like what we call bacterial vaginosis. Okay, typically the woman may have, some discharge that is not normal. Okay, and then such women may go on to have a miscarriage. You may have infections of the urinary tract. Okay, that sometimes may make women prone to having miscarriages. There are all other infections too, genital tract infections and all other kinds of infections that may contribute. But I think these two are, very common ones. Apart from infections, you have problems with the structure. Remember that when the baby is formed, that it will be the womb that carries the baby. Okay, sometimes if you have some problems with the structure of the womb, it may just render the womb incompetent to carry the baby. So what happens is a miscarriage result. You have, in this instance, the baby is normal in there, but the womb, lacks the capacity to retain the baby, till the baby is big enough to come out. So structural problems like, some women may have fibroids, that may be sometimes huge or sometimes distort the structure or anatomy of the womb of the woman. Some women may have some structural weakness, at the neck of their womb, what we call the cervix. So, as the pregnancy grows, instead of, because the cervix is supposed to stay tightly closed until the woman is ready to put to bed. But in some instances, the cervix cannot hold things up, and then gives way and the baby comes down. So we call cervical, insufficiency. So apart from structural things, there are certain things that are immune related. Sometimes there are some individuals who have immune things that basically has to do with the way our body fights into external infections. So in some instances, certain women have their bodies see the babies as being foreign and begin to fight the babies, and in those instances, you may have, such women miscarry. One such that is very common and may lead to women having repeated miscarriages would be a condition called antiphospholipid syndrome. I don't think I want to dwell so much on that because, but just know that there is a condition like that could be responsible for, repeated miscarriages. There are other things like, diseases in the mother. Okay, if you have a mom that's ill, having someone controlled diseases like, let's say, a mother is diabetic. Okay, such a woman may, apart from having a higher tendency of having abnormal babies, okay, may have a miscarriage, from complications of that problem. There are other conditions like hormonal problems in the mother, thyroid diseases, that could make a woman prone to having miscarriages. There are other things that are actually not known, shouldn't be seen as causes, but should be seen as risk factors, meaning that there are certain things you do that may make you prone, not that they are actually causes in by themselves, but they may just add up, and make women prone to having miscarriages. Lifestyle issues, we talk about people who smoke cigarettes, tobacco consumption, excessive alcohol, sometimes drug abuse, some substances that are not prescribed by your doctor when you're pregnant. Some of these may have some adverse effect on the pregnancy and may make women miscarry. It's important. I think it would be important to also mention that there's a lot of myth around miscarriages. People would be saying that things like if you do exercises that you're going to miscarry, or if you have sexual intercourse with your partner, you're going to miscarry. I think those things are, not correct. Okay, but you have women occasionally begin to blame themselves that, oh, it was because I did this, or because I had intercourse, or because I drove, or because I did all that. That's why I miscarried. But those things, it's not correct. Okay, so and I think in a nutshell, those would be some of the causes of miscarriages. But if you move over to, like we said, beyond the age of fetal viability, and you move into where we would put the stillbirths, some of the issues that would lead to stillbirth are still a bit connected to some of the things we mentioned before. But some other things, that may now come into the picture, okay, which may essentially still break them down into those that could be from the baby and those that could be from the mother. But by and large, those are some of the things that could make a woman miscarry.
It's a good thing you mentioned I was going to ask about the stress, the exercise, and all that, because a lot of people tend to tie that to, when a stressful event preceded a pregnancy loss, sometimes they tend to tie it to the reason why they lost the pregnancy.
Yeah. It's very common. Indeed, you're going to have people come in, oh no, I was overworking, I was doing that. But truth be told, while we can't completely rule out the possibility, but it's hard to define the stress that people keep talking about. What degree of stress are you talking about? I think I want to believe that in most of the instances where people attribute their pregnancy loss to stress, I think there would be some real underlying causes, and they should be interested in finding out of, if possible, other causes than just completely believe that it's due to stress. However, before I forget, let's just mention something here that let's not forget that we mentioned that between 10 to 20% of miscarriages are going to happen, and there is absolutely nothing anybody can do about it. So it just means that you have an established risk of having a miscarriage if you are a woman and you're getting pregnant. It's there. You may be lucky to go through all your pregnancies without miscarrying. Yeah, fine, that's pure luck. But if you probably were to continue getting pregnant to maybe up to 20, 30, 50, 100, you will find out that some of those pregnancies will end up as miscarriages. And that's the reason why, healthcare givers don't really bother about one miscarriage, unless there are some very clear reasons why, some staring reasons why that happened. We really don't bother about just one miscarriage. In fact, we really don't bother about one or two miscarriages. Okay, where we begin to get very worried is when a woman gets to have repeated miscarriages up to 3 times. We say consecutively. Consecutively means that you are having that miscarriage back to back. No normal pregnancies or live births in between. So let's say you had first pregnancy, you miscarried, second pregnancy, you miscarried, third pregnancy, you miscarried, then we begin to get worried. But if you had first pregnancy miscarriage, second pregnancy you had a baby, and then another miscarriage, no, we don't bother so much about that. So the other one that you have, 3 consecutive miscarriages, we call that recurrent miscarriage. That's the one we quickly try to investigate, because the theoretical probability of you having those miscarriages back to back far exceeds, okay, the one we know that is established as being normal. So that makes doctors want to investigate such scenario.
So after a lady has had a miscarriage, how how soon some people have heard someone advise someone else that, oh, okay, just try and get pregnant as soon as possible. So how soon should they try to get pregnant again?
Okay, I will advise that the management be individualized, because you see, while it is possible for a woman to just get pregnant, soon after a miscarriage, even without seeing her normal period, it's very possible, and she can go through the subsequent pregnancy without any issues. But you see, the doctor or the healthcare giver should be able to assess his or her patient, because you see, there are so many aspects to miscarriages. There's going to be an emotional aspect. Of course, you've got to get to in as much as we know that, to get a woman really back is is when you can take her back to that state that she was, that she can say, no, I'm pregnant. All right. If she loses a pregnancy, she wants to get back to that state. And in as much as we know that's really what we want to do, but we should be careful and try to assess that woman. What if, there were issues, there were certain things that contributed to her having that miscarriage? Allowing her immediately get into another pregnancy, you may not have dealt with, what caused the miscarriage in the first instance. Okay, and then not to forget, her emotional, health is also very important. Is she ready to go through? Has she gone through that grieving process? Has she, because you see, women react differently, to miscarriages. There's some who are able to just, okay, and they are getting back, all right. Those who probably need some months or so to just grieve and really be sure that they want to get back, okay, to getting pregnant and all that. So I will say that the care should be individualized. Okay, however, I don't think I want to advocate for an immediate swing back into pregnancy. Okay, I think a woman should allow maybe about 2 or 3 months or thereabouts, okay, to just try and have a few periods coming. There are those who actually advocate for women being on some, some contraception, okay, so they can go through that period and really get ready, to get back, to that pregnancy state. But my general advice would be that you individualize the management, assess your patient, the needs, of course, and then make a decision, or discuss these issues with her, and then, let her make an informed choice as in what, as to what she wants. Okay, if she's not yet ready, please offer her some contraception. Let her get to that stage, both physically and emotionally, that she's ready, to get back, into being pregnant again.
So Please, can you tell us, for the benefit of the moms, what are the signs, what are the things that a mom would experience in pregnancy that she should be rushing to the hospital as opposed to staying at home to see what happens after that?
Okay, we call those danger signs. Okay, I want to believe you're asking about the danger signs
Yes, yes,
in
yes,
relation to miscarriages, right?
yes,
Or
yes.
in relation to pregnancy generally? Yeah, no.
Well, yeah,
If
if
you
you could answer these two questions, because yeah, that would really appreciate it.
Okay, but if you're asking first in relation to miscarriages, generally
Yeah.
you don't want it. So any sign of blood anywhere, I mean blood from your vagina, okay? No matter the quantity, it could be worried, or at least get to see a doctor, is if she starts having um, lower tummy pains,
You have
okay, lower abdomen pains, yeah, and it's even worse if she gets to experiences lower tummy aches, um, increasing intensity, you know, and then she's noticing that, oh, there is a, a pattern to these pains. It's coming off and on and all that. She should, try to see her doctor. Of course, you don't want any woman that's pregnant, falling ill. By falling ill, I mean you had a fever, you coughing, you're just not feeling well. Yes, that pregnancy can sometimes make you feel unwell, but I think for the benefit of any doubt, you should. If you're not very sure of how you feel, you should try and get your doctor to actually assess you and just rule out any of those issues. Of course, we spoke about things that are, could lead to miscarriages, and we did mention something about an infection. So,
Yeah.
infections may, even though we know that it's not all discharges that are really, really sinister, could lead to miscarriages. In fact, we have a lot of women in pregnancy have yeast infection and they could discharge. But my advice would be, if you're a woman, you're pregnant and you think you're having an abnormal discharge and that you're not happy about, you should try and talk to your doctor about it. And if you have any problems with urinating, pregnancy actually would make a woman go to pee a bit
More
more
frequently
often
than usual.
than usual. However, if you notice that in addition to that, you're also feeling some pains when you're going to pee, then that's abnormal, and you should try and see your doctor about that. If suddenly, I think generally you should just complain. Then later on in the pregnancy, while we talk about all these things, we would have to include things like you seeing water, you just feel that you're getting wet down there, and or water trickling down, and you're sure that it's, even if you're not so sure it's urine or not, water should not come down, so you should go to your doctor and get checked, and of course, if later on in pregnancy, because your mothers begin to feel their baby's kick and move from about the 18th week of pregnancy, okay? And although old timers may feel that it's like 2 weeks earlier, if you're a mom and you have been perceiving your baby's kicks and movements, and all of a sudden it's like your baby just
Okay, I think there was a challenge with the connection. So we'll try and see if we can get Dr. Kaiden back. So we've had a very informative discussion. I think it's really important that as moms you understand everything from the psychological aspect, which is what we did with Kachi yesterday, then from a fellow mom, which is what the basis of our discussion with Miriam and myself last week, and then also from the medical aspect, so that we know exactly what exactly could be going on with our bodies. So Dr. Kandem is back. Welcome back. I think I had an issue with my connection. That's why I went off. Hello? Can I hear you? Okay, I can hear you now. Yes. Yes. You were telling us about the warning signs, the danger signs, and we stopped at where we stopped hearing you was when you were talking about fetal kicks. Fetal kicks.
yeah I Yeah, I said that, because remember we also spoke about stillbirth,
Yes.
which we said, yeah. So absence of fetal kicks will be an important danger sign, much later in pregnancy. You know, babies and it's coming again, and it's becoming stronger. You know, and usually too associated with this pain would be um, things like some women notice some discharge that pretty much looks like a mucus. Okay, sometimes maybe some stain of blood. We call that show. So you have pains and you see that. Very rarely too, some women may break their water. So once you see any of these, you know that, oh, it might just be labor, and you should quickly get to the hospital. So I think apart from all of this, every woman should be advised to register and get seen by a doctor who knows what to do. Okay, because most of these things could easily be wrapped up by some of the routines that are done to pregnant women when they're, when they go to the hospital for antenatal care. They get to check for, the common killers, okay, of women when they are pregnant. Okay, so they try to check things around blood pressure because it could be complications around blood pressure. They get to check the woman's yeah, urine, weight. They do all of those checks, and then of course they get to check the baby. The baby is growing well. Of course, they check to see whether the blood level is good and stays so throughout the pregnancy. So once a woman does that and is in that care and gets checked regularly, it's very unlikely that there may be any of these issues.
So please, I'd like you to tell us who exactly is a candidate for preconception care.
Yeah, preconception care will be that care that you give to a woman who is planning to be pregnant. Okay, because it's been found that the condition which a woman goes into pregnancy determines to a large extent, the outcome of that pregnancy. So a lot of women may just be there and they have some, issues. Sometimes they don't know. But by the time they are pregnant and the baby is in the picture, those issues have a way of, complicating things. A particular group that I would like to mention here would be women that have medical disorders. There are so many women who actually are ill, they are on some treatment for certain things. Maybe you have a mom that's diabetic. Okay, such a woman should be